Dr. Eric Jacobson is Chief Clinical Officer at Upstate Caring Partners in Utica, New York, where he leads a clinical department of 90 staff and drives innovative, evidence-based care across the lifespan. Dr. Eric Jacobson is a licensed psychologist and certified school psychologist with more than 25 years of experience serving individuals with developmental and psychiatric disabilities. Dr. Jacobson spearheaded the behavior analytic transformation of Upstate Caring Partners, UCP, and expanded research across 4 active lines. The work that Eric and his team are doing at Upstate Caring Partners is truly remarkable and represents the kind of innovation that needs to be shared more broadly. By sharing this work, we can help expand high-quality supports and services for more than 400,000 people across New York State who need them. Eric also developed a summer externship program focused on complex developmental disabilities, creating a strong pipeline for future clinicians and researchers. Beyond his organizational leadership, he is an adjunct instructor at Hamilton College, an athlete, and the proud father of 2 college students. He is also the spouse of Dr. Jean Jacobson, Vice President of Clinical Services for both ACANY and LIFEPlan CCONY, where she leads much of the organization's clinical work in support of more than 50,000 members. We are proud to have Dr. Eric Jacobson with us today.
Okay. Yeah, you know what? I'm psyched to be here today. This idea that you talked about sharing ideas has been so crucial to my ability to move our program forward, particularly over the last 7 or 8 years, where I feel like I've had the most growth as a clinician, as a leader. And a lot of that comes from networking, from benchmarking to see how other people are solving similar problems, both throughout the state and throughout the country. So really excited to be here today and share my presentation on turning the corner, practical approach or path to crisis stability in residential care. What's funny was I was reflecting on this morning is over my 20 years at Upstate Caring Partner, I feel like I've turned the corner at least 100 times. That's one of the neat things about this industry is there's always ways to improve quality. You're always addressing new complex issues, and turning the corner to address those is something that you always need to do. So let me pull this up and we'll get rolling. Okay, great. So anyways, we're going to be talking about a path to address crisis and instability in residential care, particularly coming out of our COVID crisis. This has been so crucial with all the different obstacles that were put in our path. Stability was one of the things that we were really challenged as an industry. So going to chat about that, but also going to chat about some things that we've been doing both before and then after COVID period. Thanks. All right. There we go. All right. So here's the agenda for today. So I like to talk about residential care. Complex developmental disabilities is sort of like riding a wild horse. Here's me. Somehow I got put on a horse while I had a suit on and I put chaps and had a lasso. And that was one of the remarks one of my professors said, is that oftentimes in these complex situations, you feel like you have control at the beginning. And then it's kind of running its course. But over time, you get more and more control with how to address these complex issues. So chat a little bit about Upstate Caring Partner as an agency. We're going to talk about the metrics that matter. And metrics have been always important, but they've become more important through this period of time. I'm going to talk about how I've built capacity within my clinical department. Talk about a treatment framework for addressing complex needs. And then we're going to talk about Ukiro. If you haven't heard about Ukiro, this has been a game changer for us at the last quarter of 2025 and into this new year. And I'm excited to share some of the outcomes related to that. And then I'll share some broad outcomes that we've been able to get to along the way and the future direction of our department and agency. All right, one thing you got to know about me is I get psyched about things. I start talking fast. I'm going to try to dial it down, but I have had a couple cups of coffee today, so I may be going full blast. If I go too fast, please put a remark in there and I'll try to slow down for you. I'm going to throw out a lot of ideas here today. Some of them may stick, some of them might not. These are really directed at residential care, more complex needs, and the issues that come along with that. But there may be some things that others that aren't in that boat will be able to gather from this discussion today. All right, so some of the crises we faced along the way. These are things that are so evident throughout residential care, but looking at everything from kind of staff injuries, restraint injuries for the people that we support, issues related to elopement, workman's comp, staff turnover, particularly during the COVID period where that was such a powerful issue that was being impacting our program, issues related to self-injurious behavior, aggression. And then what I found along the way is us not really having a good understanding of what was going on within our program. And why I say that is that was some of the complexities that we deal with in this large organization. So this is us. We're Upstate Caring Partners, a very large organization within the Utica area. So we're kind of spread between Syracuse and Albany. We cover 4 county areas. We have roughly 1,700 staff that provide these services from, when I talk about the OPW and the IDD side, it's from early intervention all the way up through adult and through life, that we're able to provide that both in day and residential care, as well as out in the community. We also have primary and psychiatric care that we provide through outpatient services. So it's a neat organization. What I've loved about it, and I've been here almost 20 years now, is your ability to impact a lot of lives within this more rural area as a whole. Utica is kind of a small city in New York, but the rest of the area around us is more rural. But you can really have a big impact on the IDD community within this organization. So here's some numbers for us. We have about 300 students that are in our EI program. Our preschool program has around 170, 18 classrooms. 8 of those are self-contained classrooms, which allows us to deal with more high-end kind of acute needs. We have our Trade Winds program, which is our 5 to 22 age program, and that provides about 190-ish students for day services, and around 72 of those students also live with us in residential care in our children's residential program. And then our adult services are really spread throughout that 4-county area. And so we have 21 houses, 225 adults that we're providing services for. So this, when we talk about the organization, is really spread pretty wide, and having a good understanding of that organization has certainly been a challenge. This talks about some of the acuity. So our populations that we work through, so when we're looking at, that 300-ish individuals that are in our residential care between our children's program and our adult program, around 246 of them, or 250 have behavior plans, with around 130-ish with some layer of restrictions that are in their plans, from anything from medications to issues related to locks, alarms, those sort of issues. We have 54 individuals with one-to-one care. We deal with elopement spectrum from leaving supervised area, high-risk kind of situations, to kind of challenges with attempting to leave areas, self-injurious behavior, PICA. Those are all part of what we address in our behavior plans. Over the past year in 2025, we had around 127 or 170 instances of aggression towards peers. So these are things that we deal with. And we approximately have around 10 injuries from all level of injuries that occur in program related to managing challenging behavior. And about 50% of those in 2025 received some level of care outside of program. What I'm excited about was that UCARA that I talked about early on has had a significant impact on staff injuries and reducing the needs for restraints in our program, and more to come about that. All right, that's our population. We're down on the more severe high-end needs. And so what I want to do is, first thing is to just jump into data. Love this mug, nice story. Now show me the data. I think this has been a hallmark of an organization that is spread so wide throughout this area, is a lot of times you would have narratives that were driving the discussion around needs, around acuity, around high risk, instead of necessarily having a good understanding of what that data suggests is going on in the program. And in 2025, we really embarked on having a better understanding of data, particularly around high risk. How do we reduce risk is we want to understand risk. And so these are some of the metrics that have been crucial for us for understanding risk. Looking at our restraints that go on in program, any PRN use. Those are SED restraints. So we have both our residential and SED restraints, aggression, towards peer, any issues related to minor injuries or injuries that are coming through minor incidents, self-injurious behavior that results in a minor being developed, safety assessments that we do to address needs in program when they exceed what our behavior plan can manage. We do safety assessments and safety plans. We look at staff injuries, elopement, 911 calls that result in police coming to the program, ER visits. We have something called a special review process that I'm going to talk to you a little bit more about how we address high needs with more resources in a more process type of way, as well as how we look at high risk leaving supervised area, which is kind of a lagging issue that can increase the likelihood of an elopement situation. So we want to have a good understanding of those situations. These are overall our high risk situation or high risk metrics that we are looking to understand and to be able to analyze and be able to use that to provide resources back into program. All right, so looking at what are the metrics that are most important to us and how do we get those in a way that we can understand those metrics. So if you're in an organization where you don't have a good understanding of metrics, this has been so helpful to us is using Power Apps through Microsoft, the Microsoft suite, and to have a better understanding of bringing those metrics in. The first thing I want to show is this initial incident notification. This is the way that we're able to get firsthand information related to any significant behavior occurrences, as well as medical issues, other issues that are more operations issues that are happening in program, and they're able to come into our system through emails. There are other ways that you can get notified through this system, but that you're also able to get this information into a database. And that's what's so crucial to understand your metrics is you have to have them in an aggregated database. And from that, you're able to make some decisions, analyze, make decisions along the way. So initial notifications is big for us. We use that to track any instances of high risk leaving supervised area. If there's instances of self-injurious behavior that has resulted in someone needing to go to the ER, any issues related to peer aggression, those sort of things we're able to track through this. We're also able to look at how we can, go back. I'll make sure that I got that right. It's like, okay. I'm sorry, there was a little note up here, but I think that's just coming from WebEx. All right, so the other thing that we have down here is able to track incidents of restraints that are occurring in programs. So that's another one of our ways that we've used Power Apps to track key information that suggests that there's a risky situation. So we track any issues related to restraints that occur in program, issues related to PRN use. We track through our Power Apps as well. We look at staff injuries that are in there that come out as a different app, and we're able to understand the level of injury that are there. These things have been crucial for us. So let me show you next a little bit about what this data looks like for us. So this is kind of de-identified information along the way. This gets set to people that we support. We're able to track information related to restraints, PRN use, any issues, and this is if they're one of our school students in the school, aggression towards peer. If there's an injury that's related to that occurs that's from unknown origin, we're able to track that. Self-injurious behavior that has resulted in an injury, any issues related to staff injuries, elopement, 911 calls, ER if they've had to go there, if they have a special review, and that's our way of looking at if we're addressing the issue. We also track issues related to are they on one-to-one in terms of supervision, and do they have self restrictions in place. So anything related to, and we track these as well. What we're trying to do is get to the least restrictive environment as possible. So we try to reduce restrictions, but we also want to make sure that we're understanding our needs related to our individuals in our program. So if someone does have restrictions, they're high risk for injuring themselves, injuring others, we have those restrictions in place, but we also track those along the way. And then the last one down there is high risk leaving supervised area. Individuals that are challenged to stay within their cohort, maybe leaving their residence, maybe challenging to stop them These are ways that we want to track, we want to understand, and we want to make sure that we're addressing those needs. And then we're also able to address it on a program level. So same set of metrics, but you're able to aggregate those metrics and you look at which programs need more help or are addressing higher needs within their program. Again, it gives you good data for understanding how you should deploy resources, knowing that we have only a certain level of clinicians that are in our program, and we want to make sure those clinicians are addressing our highest risk related to the needs of the program. And I'll talk about that in a second. All right, next thing down, this is one of the cool things that we've been doing over the last kind of month. We're tinkering around with this, trying to get a good understanding. So we have all these metrics in. We also want to rank order those metrics and weigh them according to which risk pose the most for the individuals and the people that we support, as well as our staff. And when you're able to get those rank orders, then you can weigh them by not only the metric itself. So elopement is one of our key metrics that we want to reduce. High risk for serious injury happening for those individuals that we provide services for, and can put staff into a challenging situation as well. But then we also want to know how recent it was. When you have behaviors that have occurred more recently, you're more likely to see that again. And so this is what we're looking at right now, is how do we weigh both the metric itself, the frequency of that metric, as well as looking at ways that, or how recently has it occurred. When we're able to bring the two of those together, it gives us a good understanding of overall risk. Again, this is something that's in the initial phases, but it gives us that we're going to be good looking through some iterations to try to fine tune this so that we can keep our risk level as low as possible. All right. So capacity building, big thing that I've been doing over, I would say, my best capacity building has probably been over the last 8-9 years when we really changed our model to a more behavior analytic model. In our past, when I started in the organization in 2006, we had clinicians that were in this department that came from all different walks, master's degree in social work, school psychology, general psychology, but no one with specific expertise in evidence-based practice related to individuals with intellectual and developmental disabilities. But they gained that experience along the way and that training along the way. And so what we've been shifting to is looking at how can we address the needs that are in our program? How can we assess problem behavior in an expert way, particularly for those individuals that are most at risk for self-injurious behavior, injuring others, and kind of safety areas. Looking at how we can consult with our staff related to those problem behaviors and address those and try to keep those low, provide direct treatment, particularly for the most challenging individuals. I think that was one of the things early on, when I came into this industry, particularly residential care back in 2006, realizing some of our most challenging cases we are putting in the hands of individuals, the treatment in the hands of individuals that have not experienced any education related to that treatment, aren't provided more certification around evidence-based practice, maybe coming in with very limited experience prior to doing that, and then they're giving a very long behavior plan that will be a challenge to implement. So how can we provide that direct treatment, both assessment and treatment, look at ways that we can coach around proactive intervention and strategies, and then finally, how do we train staff around evidence-based practice? That's really a key for me, is the deployment of evidence-based practice for individuals in our program so that you can build skills, because skills improve the quality of life, and that's what's so key to me. So this is kind of what the department looks like overall right now in 2026. We shifted from those kind of generic or broad kind of clinicians in our program specifically to employing BCBAs in our program, board certified behavior analysts, which in our region, there wasn't a lot. When I started this back in 2017-ish, and started looking at practices that are more geared towards behavior analysts, we had 0 in our program. We had some consultants that came along. We hired our first one at the end of 2018. Right now, we have around 25 BCBAs in our program, so we're one of the more We employ some of the most BCBAs, at least in upstate New York. And we've been able to expand the overall model along the way with different levels, including VPs that are part of this process. All right, so this is some of the growth that we've seen. We hired, we sent a lot of our, some teachers, some clinicians to go back to school to get their BCBA, but then we also have been successful at recruiting outside of the area, which was surprising. Not too many people oftentimes think about going to Utica, New York for their career, but we were able to get staff from over 9 states to come to Utica to help us build out this program, as well as to get experience in some of these evidence-based practices that I'm going to talk about in a bit. This is what I absolutely love about the Behavior Analyst Certification Board is the specification of specific skills that you need to both be able to understand from an exam standpoint, a didactic standpoint, but you also need to display those skills. These are skills that are founded in evidence-based practices. These are skills that will get to the outcomes that you want to get to for the people that you support or that your program supports. You know, for me as a psychologist, I was trained in a broad set of skills. I had a good understanding of cognitive behavior therapy, some understanding of applied behavior analysis, but not some of the specific details, the nuts and bolts that you need in order to deliver on those evidence-based practice and get to those outcomes. And this is what is absolutely great about this field of ABA is having these skills. But also you need to have programs that are going to be able to supervise around that. And that's what we've built up over time, is having supervisors that can provide the experience to our registered behavior technicians, which is our high school and bachelor level individuals may be going back to school, and our board certified behavior analysts, which is our master's level folks. I also have to say that the agency has been spectacular at supporting the development of our BCBAs in our program by sending people that either have master's degrees or want to pursue their master's degree, sending them back to school, providing tuition support, very significant tuition support, so that they can gain that degree and then deliver on those practices. One of the things I'm really excited about right now, Nick mentioned a little bit about our summer externship that we have, is this kind of ladder that we've developed over time. Is how do you move from a behavior tech, registered behavior tech, ABA instructor, BCBA to a senior BCBA. That's the line that we're getting at. Right now, what we've really focused in on is looking at bachelor's level people that can come into our program, fill our behavior tech, registered behavior tech line, and then we can send back to school for those that are qualified and talented folks that we want to send back to school and support their journey to become a BCBA. We're in the process of setting up a program through SUNY Polytechnic Institute in the fall of 2026 to provide a RBT course that's going to be led by our VP of Behavior Analysis, John Horn, for students in that program so that they can go through the course sequence related to becoming a registered behavior technician and then come on our site so that they can get some supervised experience, practice some of those skills, and then our goal will be is to get them into employment after that. Maybe it's an internship first, maybe it's going to our summer externship that we have every summer, and that ultimately we want to look at ways to get people in the program. I think we all in this field struggle with getting staff into the program, and this has been so key for us is looking at different ways that we can do that. And these are some of the examples of that. All right, so I want to get into some systems work into our program. We like to call it happy, relaxed, and engaged. We've been on this journey from about 2018-19, looking at ways, how do you create an environment that the people that you support can be happy, relaxed, and engaged, because that's how we learn best. And I think that's one of the things that our model, this kind of compassionate approach to applied behavior analysis, we don't believe people learn best when they're frustrated. We believe people learn best when they are in that HRE state, and you can teach the skills that are going to ultimately get them to the goals that we're trying to get to. And that we believe skills oftentimes lead to meaningful outcomes, and that's what's key for us. We also feel like staff are more effective when they can have an environment that they feel happy, relaxed, and engaged, and they can deliver on those skills. All right, so this is part of our RTI model, so response to intervention. When we look at challenging behavior, and that's really the focus of this presentation, is how do we address challenging behavior within our program? And I'll talk about some of these things along the way. So certainly at some of the foundations, the bottom, what we are able to provide along the way, universal protocols I'll talk about, and everyday engagement. And it looks like I switched those around. It should be everyday engagement below and universal protocols up top. I did that this morning and was not thinking. UCARO that I'm going to talk about, using skip-R intervention, some of the broad strategies that are provided through skip-R intervention. Our safety care is something that we provide in our preschool program as a way, foundation way to address challenging behavior. Then we have, for individuals that are showing heightened needs, we use our behavior plans, which is our BIPs. We use counseling in our school program when it's appropriate. And then for our highest needs, we use universal protocols, which should be skipped with that EE, should be down below, and we'll chat about both of those. I'm going to talk about skills-based treatment, which has been a game changer for us to get to outcomes, which is awesome. Greg Hanley's approach to treatment, and we'll also talk about ways that we provide restrictions around there when needed. So this is kind of a response. When you say response to intervention, if they're not responding to one element of this pyramid, then we move to the next element to address those needs. All right, so the first one I want to talk about, this is one we launched in 2025, is what's called everyday engagement. So part of COVID was the turnover that we had in program was pretty amazing. In particular, dealing with our area that is more of a rural area, was a challenge to get staff into program for a 24/7 program. Was just a wild time with looking at how you can make sure that you're providing health and safety for the individuals. What's been awesome about the agency is that they were able to create a visa program where we brought people in from other countries to fill a lot of our needs in our program, as well as continue to look in our area to fill the vacancies that were there. But there was a lot of training needs that were needed, particularly for the most high needs sites in our program or individuals that we support. That tended to be more of our children's residential program, where we had a lot of focus in 2025 around this everyday engagement. So this is, I like to say, this is bringing, having the environment where you would want your child to be in program and that you would want to work in that program. That's everyday engagement. So positive regard, always being kind, look at ways that you can create positive engaged interactions. So looking at the one-to-one staff interactions, how do you create an enriched environment for those HRE activities that you're keeping people engaged in activities they have access to reinforcers or preferences, things that they like. Oftentimes people that we support have had things that they really enjoy that bring them much gratitude. Oftentimes those things have been taken away from them because of challenging behaviors. So we look at ways that those can be provided in a safe HRE kind of way. We look at essential guidance. So how do you work through giving demands, having denials in a way that's not going to increase the likelihood of problem behavior? And then finally, how do you respond to challenging behavior? So challenging in a compassionate way, understanding that the individuals that we provide services for have experienced a lot of adversity, and we want to make sure that we're working through any challenging behavior, not in an authoritarian way, but in a compassionate, nice, positive way, knowing that those situations can be challenging. So the way that we went about doing this in our, of the 72 kids that reside with us, and that is in 10 houses, we have 212 beds. All the other beds are all 6 beds, was going through this everyday engagement core component. So really we needed this to be a program initiative. Oftentimes when you're rolling out clinical initiative, it can look like it's just coming from the clinical department. So we really looked at how we can make this a collaborative experience. This is both something that we wanted buy-in from our administrative staff, our clinical staff, our nursing staff, as well as support staff that are in program, including our DSPs that are there. We wanted to work heavily at the beginning on rapport building from our clinicians that we're going to provide the training around this. So you weren't coming in and quickly, just trying to make a lot of changes. We know not everybody likes changes. And we wanted to go heavy on building rapport that we were going to go do this together. We then structured around behavior skills training as our main way of providing this training to our staff. So behavior skills training is really just a nuts and bolts way of building up skills so that they see the specifics of it, and it's less conceptual and more specific. And we provided those, and I'll talk about that in a second. And then key for us was really coaching. And I think this is where a lot of systems fail, is they focus on didactic training, maybe a little around behavior skills training, but there's not formal feedback systems in order to shape up the system in the manner at which you're going to be able to deliver the outcomes that you want to get to. And so that was a big one for us. These are another one that we tracked through our Power Apps and Power BI reports, is to be able to look at individuals that had integrity checks or coaching done, and that you were able to address those through our individual meetings, our project plans, where we're able to see who were the staff that needed more support. How can we make sure that we're on the same page with giving them support both clinically as well as administratively? And then we went, as you're able to work through that, staff were able to show progress with delivering on everyday engagement. You were able to fade back and look at ways that you can move to just to a maintenance phase, just make sure that you were continuing to deliver it, but then able to go to a new house and shape up that house as well. So a lot of feedback loops were so important. All right, so this is behavior skills training. Big part of it is you're going to look at how you can provide instruction, how you can model, rehearse, and provide feedback. I say if you're in your program and it's solely didactic, but you want staff to show a particular skill, this is just crucial to be able to do that. Behavior skills training is an evidence-based practice founded in applied behavior analysis. Highly recommend looking into it if those are the outcomes that you want to get to, or those are the changes that you want to see with your staff. Here's some of our staff, a lot of our staff from Ghana here that were in this training. These were 15 to 30-minute behavior skills training modules that we went through. That's key for it. We knew that some of the pragmatics of running a residential program is you have limited time, and we had to make the biggest bang for our buck. So some of this was providing the training and then providing all those coaching sessions after, where you are one-to-one, you're in the moment, you're able to give some feedback on the floor. And then these were the ways, this is some of the stuff that we tracked along the way as we were doing that behavior skills training, just to make sure staff understood, knew what they needed to do, and then were able to deliver on that in program. These are things, again, that we were able to put into our Power Apps, able to track, able to trend, able to provide feedback, and able to shape up. So here's some of the data that we saw along the way. So this was kind of going back, and you'll see this mostly early. This is one example for individual in one of our programs. And what you see here is a scatter plot, and that 80% line is what we want staff to get to. We want them delivering on 80% or higher. Obviously we want to go 100%. Can't always get there, but 80% or higher in our everyday engagement metrics that they were being coached on. And so as you see along the way, you see a movement towards higher and higher percentage in that scatter plot. This is an example for this individual as well, as once this everyday engagement was employed, staff were showing more proficiency with it. We showed a sharp reduction in restraints that were needed for that individual. And that was pretty stable case that we saw along the way, which was great. This is a house, and we look at as a whole, how were they doing across all individuals that were in the house. This is a 6-bed house. And you're able to, again, see that movement towards that 8% or higher percentage of integrity related to everyday engagement. Again, for this house, they showed a nice reduction as well. They were in a bit of a downward swing, but overall showed this reduction over time, which was good with this everyday engagement. Again, a lot of it, what you're going to see is better interactions. You're going to see more access to preferred activities. For individuals that don't have individual leisure skills, we want to look at ways that we can engage them in things that they enjoy. so that we can reduce the likelihood of frustration. This is another example of that, another example of reduction that we saw over time. And this is on an individual level as well. Okay, so that's everyday engagement. So for some individuals, if they're showing increased problem behavior, what we're going to get into is a more specific way to keep some of the heat out of the kitchen. We want to reduce the amount of frustration that individual may be experiencing while we're trying to get some treatment in place. And I'll talk about treatment in a second. This is a milieu strategy. This is for everyone that is in the program and what we call universal protocols. This is where we started out within our program, and we were doing it for everyone. What we realized is this was kind of an overkill. Not everybody needed this level of kind of mollification, for lack of a better word, to keep that fire to keep that fire in the belly low. But these are for individuals that aren't responding to everyday engagement. They're engaging in challenging behavior. We look at ways of establishing a more specific universal protocol. How this differs, again, it's trying to build positive relationships. It's the best thing we can do. Positive relationships between our direct service professionals and the individuals that we provide support with. That's going to keep the fire low. But if it's not doing that, these are some of the things that we want to make sure that staff are doing, that they're following the person's lead as much as possible. I'm just going to highlight the red arrows there. We're looking at ways that we can reinforce early warning signs. And this is key, and this is some of the things that our staff struggled with, is looking at ways, how do you decrease the likelihood of very significant challenging behavior, is that you reinforce early signs, particularly if you know what they want and you're able to give them that we want. We're going to reinforce that because we do not believe that individual is going to learn with a lot of fire in their belly. We're going to look at other ways to do that, and we're going to talk about that in a second. But that's not our goal, is to get them very frustrated and feel like they're going to learn that way. For a lot of individuals, that's just not where they're going to do it. We're going to look at ways that we can decrease non-essential demands, denials. Again, this is a game changer. Oftentimes, when you look at what increases challenging behaviors, is an inappropriate redirection related to a request that's being asked or related to that challenging behavior. So if it's non-essential, that means it's not a safety issue. We're going to look at ways that we can decrease those non-essential demands, denials, so that we're giving in. And that's what other people would look at that as, but it's giving in that moment, and then you're going to teach it another time. And then you're going to invite the person to participate. Again, this isn't an authoritarian approach to treatment. We're really looking at how you can have a dignified way to provide that treatment, and how do you provide a milieu where that person feels heard, where they feel like they have control over their life. And that's the ways that we're looking to do it. So that, give choice, make instruction nice. Those are some of the things you focus on in universal protocols. All right, so this one here was another game changer for us. This is Greg Hanley's skills-based treatment model. So what the skills-based treatment model involves is, number one, conducting practical functional analysis or assessment. And that's really looking at more of a functional analysis, which is different than a functional behavior assessment, but it's an expert-driven ways to understand, can you turn some level of or first off, I should say, can you make the person happy, relaxed, and engaged? They seem like they're in the position that they enjoy being in. And can you create an environment where they show early signs related to the challenging behaviors? So those warning signs that you're going to see along the way. What's important with this practical functional assessment is you understand what turns on and what turns off problem behavior. Because if you do that, then you're able to incorporate that into the model of treatment. And that's what's so crucial about that. Oftentimes, we really don't understand what turns on and turns off problem behavior, and that's what this model provides. So looking at that, really what it starts with is, once you're able to turn on, turn off problem behavior. So for example, the individual really struggles with their tablet being taken away. And oftentimes you may have kind of stark, changes where someone needs to go to an appointment, tablet gets taken away quickly, increase in problem behavior. This is just an example of that. That's something that we're going to want to understand in that assessment. Is that a condition that will likely turn on problem behavior? And that if we give it back, would it decrease problem behavior? We know that that's one of those conditions that's going to be important for turning on, turning off problem behavior. Once we're able to establish that, then you move into functional communication training, which is an evidence-based practice to replace problem behavior with an appropriate communicative response. So basically, instead of engaging in that challenging behavior to get the tablet back, you're going to teach them a way to access that. Greg Hanley, they call it My Way. There's other iterations of it. But when they say My Way, and this is going to be unique, not many times are using the phrase My Way, you're going to be able to access specifically what is going to be that My Way reinforcer, maybe the tablet, something, maybe the tablet was something else, some way that that person is interacting with them. But you're going to be able to access that. What you're going to do at that point in the skills-based treatment is you're going to teach the skill of when you need to access something, when that tablet looks like it's going to be taken away, is you're going to say My Way, you're going to get it back, and you're going to build trust along the way through that process. Second thing is once you're able to establish that, you're able to establish trust. They know that when I say My Way, I'm going to get it back, is then you start working on toleration, longer periods of time before you get it back, but that you know you'll ultimately get it back. And there's a lot of nuances with this, so this is just kind of a quick overview of the model. Once you're able to do that, you're going to work on relinquishing that person, them being able to give the tablet to you, knowing that they're going to get it back at some point. And the way they get it back, and the cool thing about this model is it's done in a way that becomes less predictable over time. But once trust is built up, they know they're going to get it. It's just not a one-to-one manner that they're going to get it back. And then you're really going to work on, once you're able to go through those 3 steps, you're going to work on transitioning. And that transitioning to activities and skills that you want to build. And these are the ones that are really important for our population here. You know, for individuals that are in our program that are more on the, have both intellectual disabilities with and without autism. So those profoundly autistic that are in our program, is building these skills that are so important, that are often challenging to get to because of those challenging behaviors. So activities of daily living, anything from toileting to dressing, to anything with mealtime type activities. Looking at building their language or communication is something that's important for us. Leisure, again, is such a crucial skill, particularly in residential care. Independent leisure skill is even more important in what we focus on. Looking at ways that we can build safety skills, exercise, knowing that that's crucial for decreasing problem behaviors, having a good amount of exercise during the day. And then looking at group skills. So staying in a group, being able to participate for things in a group, doing things in a group, again, are so crucial for residential care because you only have a limited number of staff to provide that one-on-one. You're trying to reduce that need as much as possible and build skills that they can stay in a group in a parking lot or going to the grocery store, out to a restaurant. Again, such crucial skills to focus on. These are some of the skills that, again, that we focus on during those. These are the necessary 9 skills that are part of the Essential for Living. Pat McGreevy, Troy Fry's group, they're part of our consultants that we've worked with in our agency and part of our clinical advisory board. Again, these are for individuals in residential care with more complex needs on moderate severe disabilities. These are just crucial skills for all of them to have. Our history before this, we focused on skills that, like this started out of our Trade Winds program, often look like what you should work on in skills, worksheets. We did a lot with analog clocks in our program, knowing that you aren't using analog clocks that more, but it was kind of like what you should do in school. Instead, we focus on these. We try to do it as much in a naturalistic setting. We call it event-based teaching, where you're able to teach in that context that you need that skill. Not as a pull-out session, but you're pushed in, you're in the classroom, and you're teaching the skill at the time that you need the skill. All right, so those are kind of how we use our clinicians to address those needs. That's all, when we're talking about our skills-based treatment, that is our BCBAs, that is our RBTs in some cases when they've been able to learn these skills, and trying to have that individual treatment for those more complex individuals instead of putting into a behavior plan. All right, so this is the next thing we want to talk about is our special review process. So I'm a big fan of process. I'm in a new room. I just got in this room a couple days ago. So my banner is down a little bit and I'm covering it with my bald head. But trust the process is one of the mantras I like to go back to, and knowing that change doesn't happen immediately, but you have a process to get to the outcomes that you want to get to. This is one of the things that has helped us quite a bit, is how do we get our treatment teams to be as impactful as possible, instead of having all your resources kind of go around like ping pong balls whenever there's a problem. And so what we do is we have a special review process, and that starts with an additional review that's led by one of our senior behavior analysts or one of our directors that's director of behavior services. And that's to oversee cases that where you're seeing an increased risk. So that could be anything, what I showed you early on, those metrics that we're evaluating. You're showing a 4-week increase in problems, could be restraints, could be an issue related to self-injurious behavior. And we want to make sure teams are taking a deeper dive. They do these all the time in our management meetings, but we also want to have a more comprehensive meeting, and it would also involve their day team as well, because this is something that maybe their day team could also address in their day program, or vice versa. Maybe it's happening in the day program and the residential team needs to know this is occurring as well. And that we want teams to be as both focus on their data to make data-based decisions. We want them to focus on action and not just mollify, but look at ways that you can address that problem behavior. And that we want to look at ways that we can, if they're struggling still, we can get them into more resources in there, or that we can move out of this kind of additional process if they seems like everything's moving in the right direction. If it's not moving in the right direction, then we move to an intermediate review. And that's when one of our senior VPs takes over the case of behavior analysis to look at what's going on in that and follow that process. This is oftentimes where we're bringing in skills-based treatment that I talked about before. We want to making sure that we're providing the right treatment. If they're stuck in that treatment, we want to make sure that we're addressing how that's stuck. Even though there's other ways that we can do that. We want to make sure that we're coordinating with providers. And along the way, we want teams ruling out any medical issues that could be driving these issues related to psychiatric issues, sleep-related issues, issues related to hydration, anything that could be more meal-related, restricted eating, diet, that kind of stuff. Those are all key for us along the way, is getting teams thinking about the bigger issues that often are influencers on challenging behavior. So they'll have those meetings along the way with the intermediate. If that's still a concern, we move it up to a special review. I oversee that process. Again, at this point, we're looking at some outside consultants that we can bring in to provide, maybe an issue related to the non-medication treatment we're providing, but it may be also looking at how we bring in another outside consultant to look at psychiatric issues related to many medical issues to address problems that could be driving some of the concerns that we see, just to have another eye on it. If this continues to happen, then we're going to bring it up, or problems continue to happen, we're going to bring it up to the agency review. And at that point, we have all eyes on, executives are in there, we're letting them know this person that we're really struggling with. We're looking at any barriers to treatment, to safety that we can address along the way. Certainly, protective equipment is something that's big along the way with us. We want staff to be safe, and we want the individuals to be safe along the way. And so those are things that we address. At the agency level, we're going to make considerations whether we're able to provide the level of services that we need to in order to keep them safe, to keep staff safe, and knowing that this may be an interaction back with the state, in some ways back with their school district, to let them know that they've exceeded what we're able to provide. So having a process that we're able to get there along the way. And that gives you kind of a big picture overall, but this is a process that has been helpful for us to go through problems more systematically rather than that narrative. When I talked about, the story driving the narrative at the beginning in that coffee cup, rather than these narrative kind of bringing resources all over the places, we try to do it more systematically. All right. So this one here, we're going to jump into this next step. This is one that came out in kind of late 2025. We started this around September. Absolute game changer for us. I'm going to show you the data. You're going to be excited about what we're able to to get to with using these Ukuro protective equipment. This is kind of a proposal along the way that we went through. Not a proposal. We've executed it in our program. We're going to be done throughout the whole agency at the end of March, which is pretty exciting. And Ukuro is Japanese to receive. It's a hard word to pronounce. It's an easier to execute probably than pronounce. But a lot of the Ukuro involves a couple things. Is really it's a trauma-informed approach to treatment, understanding that individuals that are in congregate care that are likely to receive restraints in order to keep them safe have experienced a lot of adversity. Ukuro has a great training that both for trainers to receive, but as well as when you're rolling it out into your program. It's a train the trainer model. We have 10 certified trainers. Those trainers train our staff, but Ukuro has a great training that goes with their model that really emphasizes what an individual experiences when they're having kind of an escalated event in terms of what's going on in their body and their mind, and some of the impact of restraints and how they can be traumatic for them. And so we really try to have staff have a good understanding of that. As I mentioned earlier, many are coming into working in this field, never having done that before. So the primary goal is to prevent the use of physical restraints. It's not saying that it's getting rid of those challenges that are there or challenging behavior. We need to address that. We need to have a better way for that individual to communicate, to get their needs met. We may need to go into skills-based treatment. But again, we want to keep them safe. We see that using blocking pads is more of a appropriate way to address problem behavior, more in line with that trauma-informed approach than having a restraint. Less likely to lead to injury as well for the person that we support, as well as for our staff in our program. So again, primary goal, enhance safety. We want to make sure that staff are able to get to those pads as quickly as possible. So there is an investment in the pads along the way. And these are specialized pads, which is really cool. Actually, the agency that developed this curriculum, Ukuro, is a school called Grafton in Virginia. And we started working with Grafton in 2009 when we got rid of our timeout rooms. And at that point, they were using boat cushions. And we continue to use boat cushions as our blocking pads, in addition to some other pads. But these specialized pads are so much nicer for staff to use and so much easier to block any sort of aggression, self-injurious behavior than we have been able to get to with those boat cushions. So again, pads, key risk. We want to reduce, we want to mitigate more challenging behavior. And some of the issues that take into consideration that we need to have mild to moderate incidents is what we want to use these pads for. They're not used for everything. And that we want, if it's more of a severe issue, we want more staff to be involved with it. So it's kind of, again, it's a response to intervention and model in some ways. And some of it's depending on the person, depending on their size. What's been great is we've been able to use these with individuals that we really struggle with getting any level of a skip procedure in due to their size. We often are effective with the Ukuro pad. These are what some of the pads look like. There are some other ones as well, some larger ones that have been effective. Some of them the larger ones can be a little heavier and can be a bit of a challenge. So far, they've been very well received. Some of our outcome data that I wanted to share, I didn't get a slide on it though. Overall, the safety that staff have felt as a result of these pads have been great. Certainly in our type of setting, safety is paramount. Safety is one of the things staff always come back to say, this is how we want to feel. And Ukuro has delivered on that element of safety when we've done survey after training has been conducted. And then at, I think, 3-month follow-up, continuing to say that we're feeling that level of safety. There are some individuals that we struggle with implementing it with. We kind of work around that. That's built into our model. We track that with a Power App, and that we have debriefings on those. And we have a way to escalate the expertise of our trainers. If we need multiple trainers to get in to look at those individual cases to see if there's another way to support them with those pads. as well as I have to say Grafton, the agency that oversees the UCURO curriculum, has been great. They have a great network of providers out there using it. Many within New York State are using it as well. So if you're struggling with the restraint issues, we're struggling with keeping staff safe, I definitely say look at UCURO, because I'm going to show you some pretty awesome stats right here. So I'll let this sink in for 1 second. These are kind of some of the things that we dealt with along the way. We had really low levels of restraints in our OPWDD program during the beginning of COVID period. I think the staff turnover, some of the individuals that we support, we got new individuals in that were showing more challenges. We had some up and downs. I tell you what, the downward trend since we started this, and this was a slow rollout in our OPWDD residential programs, took a while. So we started in mid-September and just kind of slowly addressed all of our high acute needs programs that had more restraints that were occurring in them. And then we're moving to our less acute programs as we moved along. But you see that nice trend line along the way with our OPWDD programs. Wild reduction in our trade winds program. This is one we started in October in just one of our schools, and then we finished it at the beginning of November in our second school. But the reduction in our trade winds program, over 60% reduction in restraint usage, and about 50%, 55% in our OPWDD residential programs. And then we've had about a 50% reduction in staff injuries associated with challenging behavior. That, to me, we have not had that since we got the timeout rooms. We eliminated them back in 2009. And part of our timeout rooms is they were out in the hallway. So staff had to leave programs, particularly in our school programs, which had the most restraints, had to leave the classroom to go to the timeout room, and that you would have injuries that would occur along the way, and a lot more restraints that would occur that up to they can get them into the timeout rooms. So that was a game changer for us, is getting rid of the timeout rooms. But this, to me, I've just been floored by the level of drop that we've seen in restraints, which is great. And now we're at a point that we can really fine tune. We can go back to those metrics, and any sort of blips that we're seeing for individuals or programs with increased restraints, we could be on so much differently than we were in the past, because the level is getting so low right now. So again, these are staff injuries associated. October was a really high injury month for some reason. Again, it started in overall back in September. It was just a couple houses at that point. And it probably picked up residentially in November-ish. And again, October and November in our school program. But since then, we've seen a nice reduction. And when you compare from our 2025 time this year to where we are in 2026, again, it's been 50% reduction in staff injuries, and a little bit less overall agency-wide with restraints, which is just terrific. One of the other things, just looking at overall what we've been able to track along the way, this gets back to some of the metrics that I showed you earlier. These are looking at RIAs, all of our RIAs that we have. So restrictive interventions, that's the state OPWDD program, is looking at RIAs. That April data looks low. I don't think it is as low. These are some new data coming out. Really, probably more in May was when we had all of our data going into our power apps. This gets at restraints, aggression towards peer, anything that you're going to get into a minor, and then staff injuries. So overall, I think since October, we've seen this nice reduction. We're going to continue to see that. We're going to ride this occur as far as we can, and then address the individual issues that are popping up that we're seeing, which are a lot more manageable now that they've decreased. We're still waiting on our workman's comp to come out for those that are in this presentation that are looking at your finances. Again, we've seen a nice reduction, particularly in the end quarter, with any sort of injuries requiring any sort of workman's comp. So this is one, there is a cost associated with UCURO and with hiring BCBAs in order to run everyday engagement. Both of those that you'll see back in your workman's comp, which is just which is awesome. All right, so we're getting to the end here. Where are we going next? So for me, there's still gaps. You know, I'm going to be a person where there's always continuous performance improvement for our department and for our agency. Big thing right now, we're looking to fine tune this risk predictor, decrease individuals' issues related to safety for the people we support and for our staff. We're going to look at how you can make more functional data reports. So we want data to be in the hands of our residential managers, our residential managers that are clinicians, so that they can see what's going on in their data and address those. What's neat with our Power BI reports that are developed from our Power Apps is you can look at usage of that report, who's viewing the report, and you can address that if you're seeing that people aren't in there. Let's try to make it more functional. So a lot of this is getting back down into our meetings and staff just working differently with kind of understanding what their data looks like across our organizational lines. Next thing is looking at how we can integrate more positive metrics. We do have positive metrics like goal attainment, our IEP goal attainment, and our trade wins program. We're also looking at how we can integrate an annual quality of life metric into this. So not only do we want to see a decrease in problem metrics, but we want to see an increase in positive metrics, and that's really key for us. So that's something that we're looking to integrate, as well as broadly staff safety. We're looking at ways that we can work with parents differently so that they're satisfied with our program. Some survey work that's going to be coming out soon around that. Finally, looking at ways that we can scale treatment. So moving away from our BCBA solely providing that skills-based treatment to our registered behavior technicians to be able to provide it, so we can provide more of that skills-based treatment in order to get to that point where you can improve quality of life, build the skills that are really going to impact quality of life. Nick mentioned at the beginning, right now we have 4 lines of research that we do within our program. It's been pretty cool for us. We opened a division within our department for applied research. Right now we have 4 different lines that we're running with 2 kind of on deck. We're looking at some desensitization programs for medical and dental desensitization. We also look at ways that we can use that behavior skills training that I mentioned before, the nuts and bolts way to teach people how to deliver on those skills for utilizing PECs in our program. One of the main AAC devices that we use is picture exchange communication system. So being able to deliver on that. We also are looking at ways that we can train our staff, our RBTs, our registered behavior technicians, on the skill-based treatment that I mentioned. And that's another one that we're using the behavior skills training to both analyze and to see how effective we are with that. As many of you know, for those that are profoundly impacted by autism, by intellectual and developmental disabilities, there's a lack of research with this particular group. Most of what we know about evidence-based treatment is founded in younger individuals with less acute needs. And so our goal, and my goal certainly, is to leave a legacy with this. With our department, is being able to assist other programs in understanding outcomes related to evidence-based practice, particularly for those individuals that are more in the severe and profound end of the spectrum related to intellectual and developmental disabilities. So looking at ways that we can publish around that. Finally, and I think we are almost done. I got 2 minutes. Is talking about our Compassionate Care Conference. So a big part of what we've been putting together over the last couple of years is I shouldn't say last couple of years. We've done 2 conferences, started in 2022. And this is going to be coming up this summer, is our 3rd conference that we're providing in Utica. So this is your opportunity to come to Utica if you've not been to Utica, which is great. But this is an awesome conference. We call it the Compassionate Care Conference. Greg Hanley, right there in the middle, who is the founder of FDF Behavioral Consultants, will be our keynote speaker. He's going to kick off a 2-day conference. And we've always done it as a 2-day conference. We have a great set of speakers, multidisciplinary speakers, that will speak to a multidisciplinary group of people to come to this conference. Traditionally, it's been board certified behavior analysts. This year, we have Dr. Holly Brown, who's going to be speaking later, psychiatric nurse practitioner that's going to be there. We have a couple of parents that are going to speak to the issues that address that have impacted them, as well as we have just a lot of leaders in the field that can speak to how do you scale treatment to your organization. which is just, I think what we're looking at is how do you provide these evidence-based practices at scale so you can deliver on outcomes that you want to deliver on. So that's 2 days in Utica. I'm going to show you a QR code that's going to give you a little bit more about this. Here's the picture on the right was from the last time we had it in Utica. A lot of energy was coming out of that conference. What is cool is in 2000, I shouldn't say this year, or 2024, we talked about doing workshops. We said, all right, let's give it a go for 26. So the Wednesday before, there's going to be longer 3-hour workshops. If you want to dial down a little bit deeper into what the some of the crucial skills you may want your staff to have, or you want as a leader. We have one that's going to be Teresa Fiani is going to talk a lot about the skills-based treatment. John Austin and John Guercio are going to be talking about ways to deliver on leadership, particularly John Guercio, who's going to be talking soon, is going to be talking about residential care. Catherine Horton, Molly Lingo are coming from Pyramid and are going to be talking about use of picture exchange communication and how do you deliver on those systems. And then Troy Fry is going to be talking about essential for living and how do you deliver on the most essential skills for individuals with moderate to severe disabilities. So that may be a deeper dive for both you and your staff. And up there on the left, that pop-hole QR code can give you a link to all of my contact information. Within there, you can get access to the conference itself, but I'll make sure that information gets put into the chat today so that you can get a better understanding of the conference, access anything here. I spoke quickly today. I'm a minute late. Certainly answer questions for a little bit of time that we have, but as well as if there's not enough time, reach out to me. More than happy to chat with you, set up a individual Zoom session, and we can chat through some of what I discussed today. Thank you very much. I appreciate your attention. I'll look forward to the rest of the day.
Thank you, Dr. Jacobson. Do you have time for a few questions right now?
Terrific.
Awesome. Thank you. You are a wealth of information. This was great. We've had several questions come in. We may not be able to answer them all, but I will send it to you if you could answer the questions later, and we'll definitely follow up with all the attendees today and share the responses. So one of the questions that was asked was, can you please explain notifications? And this was in terms of the Power Apps. You explained Power BI and data collection, but how does the staff record data, and how do they record it in a timely manner? Can you go into more depth on that?
Absolutely. So this initial notification would, if after some sort of significant, at least on the challenging behavior end, challenging behavior occurs, individual may have been requiring the police to come to that residential site. They may go to the ER for an evaluation. Maybe they're indicating something around concerns with suicidality, and that once that situation is safe, or someone else is able that has knowledge of that situation, they're able to go into the Power App, fill out the Power App, all the crucial information. That information goes into a Power BI report, but it also goes out into out to an email to all the main leaders of the organization so that they can understand a situation that is occurring. At times they'll put in follow-up information just to update everyone on it. So that gets out that initial information. It's not the only way we communicate, but I think as most of us know, when you have any sort of communication breakdown, particularly in a large agency, can lead to a lot of problems. And so that's the way this agency has gone about not only following your natural lines. And what's cool, like if you have like going back to if there's some sort of other communication that needs to occur, they can indicate, they followed up with a nurse on that so that they know that there was some level of face-to-face contact and or phone contact with a nurse to review the situation. Nurse may have given some direction related to what should be done, but you see all the problem solving that occurred. It's in that report, and then it's put in front of people. But there are other ways that we communicate, certainly when there's higher levels of concern going on with that individual. Does that make sense?
Absolutely. Thank you so much. The next question is, does key learning for each individual create change for that individual, but also considered potentially best practice and deployed across the agency? Can you go into this a bit more?
So when you, for the individual that we support or for our staff?
Individual that you support.
Yeah, I mean, absolutely. I mean, so let me make you understand your question correctly. Does that, when they're able to have some sort of change in behavior, how does that impact the rest of the organization, or how does that impact their overall treatment?
Both. If you could answer it first
Yeah.
for the individual directly, and then also more globally for the organization.
Yeah, I mean, I tell you what, I don't know if this is answering your question, but one of the things I like to celebrate success. And I think in a position that I'm in is oftentimes you're focusing on the challenges. We have to address the challenges. We have to address safety. At times, success and skill development gets put on the back burner, particularly things that are going to improve quality of life. One of the things that I do for my monthly report is down my line, which is extensive. So I have a VP, I have seniors that are underneath them. Then it goes to the BCBAs. Is they report out on success cases each month that is tied into our treatment model. So it could be skills you're working on in skills-based treatment, but it could also be what some evidence-based practices that led to success back in that classroom. So toileting, being able to use your AAC device. And then we bring it back into my monthly report. We share those if it's appropriate, like in some of our school settings, we may share a video to show them using that device. In this industry, you need to sell change as much as possible. Change is tough. Nobody likes change. And when you're asking people to do new things, you need to celebrate that and look at other ways that you can show people what that looks like. Because oftentimes when you're able to show them, like I talked about event-based teaching, you're looking at how you can teach in a model. Maybe you're working on a congregate meal and how you can teach individual skills, differentiate for their level, and that we may tape that session and show it during a faculty meeting to say this is how they worked on those individual skills within this setting. As I mentioned, most of us, me included, did not get a lot of training back in grad school, back in undergrad, how to work with this population. We went to mainstream programs, so you didn't get exposed to it a lot. And so a lot of it is you're trying to just increase different ways you can expose the model that we're looking to move towards.
No, absolutely. We have a phenomenal audience today, a lot of great people throughout the state of New York. And one of the great questions, this is the last one before our next presenter, is that the intro mentioned primary and psychiatric care. Is this under the Article 16 clinic, or what service is this, all of this great care being provided in?
Yeah, ours is all just built out within our tuition money that we have from programs. I know other programs run their BCBAs through their clinics. For our program, and I should have mentioned it before, we made a decision back in 2000, now I think it was initially probably 2017, 18, where we were going to split our line when we started to go down to 2019 with behavior analysts in our residential program. Is we looked at our behavior specialists. We still have behavior specialists in our program. When I showed our model, their goal is to do all of the OPWD regulations, the 633 regulations in our program. They run FBAs, they do behavior plans, and that we escalate up that model that I showed you, and there needs to be more direct services. That's when we use our BCBAs. Where in the past, maybe our behavior specialists were providing some level of support. Oftentimes it was just kind of crisis management. That's where we split our line and said, okay, maybe we don't need as many behavior specialists, and we're going to put our money into BCBAs to address the most acute needs within the program. And so that was kind of a strategic plan on our part to address that and look at how, with the money that we have within the department, how we could use it best to get to the outcomes we need to get to.
Wonderful. Thank you so much, Dr. Jacobson. I really appreciate all the information that you shared today, and I will definitely remember that trust the process. So we'll definitely follow up with you. Thank you. With any unanswered questions, and then we'll provide the Q&A afterwards. So thank you so much for your time, and I am going to pass it back to Nadira Bryan, who will be introducing our next presenter.
Very good. Thank you so much.
Thank you.